Hello and namaste to everyone. This is Singh from Department of Physiotherapy and Diagnosis from Jayoti Vidyapeeth Women's University. For today's lecture, I'll be talking about disturbances in acid-base balance. So, for acid-base balance, before knowing acid disturbances in acid-base balance, so the normal plasma pH is basically your 7.4. The range is between 7.38 to 7.42. So any uh, decrease in pH below 7.38 is known as acidosis. So acidosis is the clinical state where acids accumulate or bases are lost basically. So and rise in pH before above 7.42 will lead to a basic condition, or we can also say alkalosis. So a loss of acid or accumulation of base will lead to alkalosis. So the body cells, they can tolerate only a narrow range of pH, and the extreme ranges of pH are between 7.0 to 7.6, which will lead to life-threatening conditions and may lead to death. So acid-based parameters that are to be checked in patients are with any serious illness, with multi-organ failure, with respiratory failure, with cardiac failure, with uncontrolled diabetes mellitus, or with poisoning with barbiturates and ethylene glycol. So these are the conditions in which you will check patients for acidic and basic parameters. So maybe there can be conditions of acidosis and alkalosis in these kind of patients. So further now there are various steps to the clinical assessment of acid-base disturbances. So to assess the pH, which is a normal 7.4, the pH less than 7.35 is acidemia, and pH more than 7.45 is your alkalemia. And serum bicarbonate levels are different. So and further, you can assess arterial PCO2. Then you can check compensatory response, compensation, and never overcompensates the pH. So if pH is less than 7.4, acidosis is the primary disorder. And if the pH is 7.4, alkalosis is the primary disorder. So a third one for the clinical assessment of acid-base disturbance is assessment of anion gap. Next is your assessment in the change in serum anion gap and change in your bicarbonate levels. So to assess if there is any underlying causes. So acid-base disturbances can be caused due to uh, acidosis or alkalosis. So these acidosis and alkalosis, they can be further of respiratory acidosis or respiratory alkalosis or metabolic acidosis and metabolic alkalosis. So classification of next is classification of acid-base disturbances. So it can be classified in two types: acidosis or alkalosis. So acidosis is getting acidic pH. So there is fall in pH basically. That is, your pH is getting below 7. And alkalosis is any rise in pH. That is, your pH is getting more than 7 or becoming higher than your acidic range. So for acidosis, it can be subclassified as respiratory acidosis. In case of respiratory acidosis, there is excess of carbonic acid, and for metabolic acidosis, there is deficiency of bicarbonate ions. So for respiratory, excess of carbonic acid, and there is in case of metabolic, there is deficiency of the bicarbonate ions. Further, in case of alkalosis, there is rising pH first of all. Secondly, it can be classified into two types: respiratory alkalosis or metabolic alkalosis. So respiratory alkalosis, there is a primary deficit of your carbonic acid. So in acidosis, there was excess of carbonic acid, and here there is deficiency of your carbonic acid. Next is your metabolic alkalosis. So there is primary excess of bicarbonate, that is excessive bicarbonate ions are present, and in metabolic acidosis there is deficiency of the bicarbonate ions. So both the cases are reverse of each other. So now for the there is a term called compensatory response. So each of the above disturbances, they will be followed by a secondary compensatory change in the counteracting variables. Example, a primary change in bicarbonate involves an alteration in your PCO2 levels. And depending on the extent of compensatory change, there are different stages. So these different changes were all discussed earlier. So in as we have talked earlier about the compensatory changes, there is like first line of defense, second line of defense, and your third line of defense. First line of defense by your blood buffers, second line of defense through your respiratory system, and third line of defense through your renal system. So in actual clinical states, patients will have different states of compensation, and the compensatory adaptive responses are different. So the in acid-based disturbances, expected renal and respiratory compensations can be such as in case of metabolic acidosis, expected PCO2 is to be reduced by 1 mm of Hg for every 1 millimoles per liter drop in bicarbonate. And for case of metabolic alkalosis, expect PCO2 uh, is to be increased by 0.6 mmHg for every 1 millimoles rise in bicarbonate. For acute respiratory acidosis, expect 1 millimoles per liter increase in bicarbonate for 10 mmHg rise in PCO2. For chronic respiratory acidosis, expect uh, 3.5 millimoles increase in bicarbonate per 10 mm Hg rise in PCO2, and for acute respiratory alkalosis, expect 2 millimoles per liter decrease in bicarbonates per 10 mm Hg fall in PCO2, and for chronic respiratory alkalosis, expect 4 millimoles decrease in bicarbonates per 10 mm Hg fall in PCO2. So following were the conditions during the cases of respiratory and renal compensations. So the compensatory responses are following or adaptive responses, I should say. There can be following changes, like the primary change is in a bicarbonate and it involves an alteration in PCO2, and the direction of change is same as primary change, and there is attempt at restoring the ratio to 20 and your pH to 7.4. So the adaptive response is always in same direction as primary disturbance, and primary decrease in arterial bicarbonate involves a reduction in arterial blood PCO2 by alveolar hypoventilation. And now you can always classify this types of there are different types of acid-based disturbances. Different types of disturbances are metabolic acidosis, metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. So in case of metabolic acidosis, the pH decreases. There is a deficit of bicarbonate. The ratio becomes less than 20. The in bicarbonate buffer, I told you that pH is 20. So the bicarbonate buffer ratio, it becomes less than 20. And in case of secondary change, it decreases in PaCO2. So in case of metabolic alkalosis, there is increase in pH and excess of bicarbonate, and ratio increase is above 20, and there is increase in PaCO2. And hence, in case of respiratory acidosis, there is decrease in pH and excess of carbonic acid, and less than 20 ratio is seen, and increase in bicarbonate ions. Lastly, in case of respiratory alkalosis, there is increase in pH, deficit of carbonic acid, and ratio increases above 20 and decrease in bicarbonate is seen. Now next will be similarly there is a primary increase in arterial PCO2 it involves an increase in arterial bicarbonate by an increase in bicarbonate reabsorption by your kidneys. So the compensatory change will try to restore the pH to normal, and however the compensatory change cannot fully correct a disturbance. Clinically saying, acid-base disturbance states may be divided into uncompensated, partially compensated, and fully compensated manner. Next will be your mixed responses. This term is used if the disturbance is pure and it is not difficult to accurately assess the nature of disturbance. In case of mixed disturbances, both HCO3 minus and H2CO3 levels are altered. So the adaptive response always involves a change in contracting variables. And example, a primary change in bicarbonate, it involves an alteration in your PCO2. An adaptive response is always in the same direction as your primary disturbance. And depending on the extent of compensatory change, there are different stages. And looking at the parameters, the stages of compensation, they can be identified. So, different stages of composition when I said uncompensated, partially compensated, and fully compensated. So each cases, whether it be metabolic acidosis, metabolic alkalosis, respiratory acidosis, or respiratory alkalosis, there is uncompensated, partially compensated, and fully compensated phases. And in each case, pH, bicarbonate, PaCO2, and ratios are different, whether they are low, whether they are high, or whether they are normal. And moreover, uh, this ratio can be less than 20 or more than 20, or they can be equal to 20. That will be a lot in detail if I continue with that topic. So we'll read about further classifications of these acid-based disturbances into further lecture. We'll be coming across the chemical pathology of acid-based disturbances, such as what are the causes in metabolic acidosis, what is anion gap. Further, we'll get to know about high anion gap metabolic acidosis and normal anion gap metabolic acidosis, and also the further what is osmolar gap, and also what are the causes of these normal anion gap metabolic acidosis, and what is compensated metabolic acidosis, and same with your alkalosis conditions. So that will be it for today. And for today's lecture, we had our focus on acidosis and alkalosis, and further we got to know about the compensatory responses and your mixed responses. So both of the responses, they're very important when we get across our pathological conditions. So these responses have to be read. Now, further, um, what are what are the pathologies which are related to these responses? They need to be focused on, and what are the assessments for these responses that has to be read. And further, I'll be talking in the next lecture. So that is it for today's lecture. Thank you, and meet you in next class. Take care.